Being recorded.
Good afternoon and welcome to Max. I'm down here at University of Maryland at the Maryland Addiction Consultation Service headquarters, which is where we are going to be doing this webinar. So we really appreciate having everybody join us to talk about opioid tapering, practical tips on the when, why, and how. You are all currently muted. We will have an opportunity at the end of the um, presentation for some questions and answers. If you have any questions that you want to send in during the presentation that you would like to have answered at the end, please feel free to use the chat box in your on your screen, or we will also then be able to take audio questions unless I'm told otherwise. So here we go. And I have to make sure that I can, okay. All right, so as I said, the topic for today is on opioid tapering, practical tips on the when, why, and how. And I am Yngvild Olsen and currently serving as the medical consultant to the Behavioral Health Administration, which funds the Maryland Addictions Consultation Service. So just a quick word about MACS. As many of you know, it provides support to prescribers and their practices in addressing needs of patients who have substance use disorders and chronic pain management. All the services are free, and they include free phone consultation for clinical questions, education and training opportunities related to SUD and chronic pain management, assistance with referrals, not only for addiction and other behavioral health resources, but also now technical assistance to practices that are implementing or expanding office-based addiction treatment services. And coming up at the end of March, Max is starting a tele-echo clinic, which includes a collaborative medical education through didactic presentations and case-based learning. If you have any further questions about any of this, please feel free to give us a call at the number listed at the bottom, or visit the website at www.marylandmacs.org, and we'll leave the phone number up at the end as well. So for this webinar, there are no disclosures that we have to report. And we hope that by the end, you should be able to describe 3 clinical situations in which to consider an opioid taper, apply 3 best practices to opioid tapering, and identify 3 best practices to avoid when tapering opioids. And what we're really talking about is opioids for the treatment of chronic non-cancer pain, non-palliative care, non-cancer pain, kind of not end-of-life care. And I think everyone knows to some extent a little bit about how we got here, but it's worth just reviewing. We know that between 1999 and 2010, there were a significant number of increases in the prescription of opioids and accompanying deaths from prescription opioids. Unfortunately, your screen cut off. But if you look up on the left-hand corner, you will see this figure from the CDC, from an MMWR, and it really shows you the dramatic increase in the prescribing, the sales of opioid prescriptions, accompanied by an increase, substantial increase in the rate of opioid-related deaths, as well as the opioid treatment admissions for opiate use disorder in that decade. And as a response, in 2016, we know that the CDC came out with their opioid prescribing guideline that was really targeted at primary care physicians and trying to give some guidance on when and how to really think about starting opioids for the treatment of chronic non-cancer pain, really highlighting that there was very little evidence for long-term use of opioids in this clinical condition. At the same time, there really were states, starting with Massachusetts, that took those guidelines and made laws, made different insurance policies, other policies, really to try and change and reverse the curve that we had seen between 1999 and 2010. And so Massachusetts was the first state that actually passed a law limiting the number of days that any physician or any prescriber could prescribe an initial prescription of an opioid for to 7 days. Since Massachusetts passed that law, almost half of the other states have similar laws, and we have seen a really significant tightening around the prescribing of opioids for particularly non-cancer pain. And as a result, as of 2017, we saw additional data that while opioid scripts peaked at 255 million in 2012, by 2017 they had decreased to 191 million. That's still a lot of opioids being prescribed. And if you look at this chart up here, again from the CDC, you will see that, let me just go back to it. You will see that the annual prescribing rate has really dropped, especially in that high dose was considered to be greater than or equal to 90 morphine milligram equivalents per day. But we still have this legacy population of about 18 million Americans that are taking long-term opioids for chronic non-cancer pain. So what has happened, and why are we then now really focusing on opioid tapering as a specific topic? Because since 2016, with this tightening of opioid prescribing, there have been reports in the popular press as well as in the medical literature around patients with chronic pain who are kind of getting caught in this opioid prescribing debate, as the story on NPR from July of 2018 mentions. And in fact, efforts that really seems to suggest that maybe the pendulum has swung too far to the other side. So sometimes what happens when we try and address a public health issue, we put in place policies and other efforts, and we need to be wary and careful of kind of potentially unintended consequences. And there were a number of experts, clinical experts, researchers, and others who published in and signed a letter that was published in Pain Medicine that really shows that, or where they essentially kind of indicated that forced opioid tapering is a large-scale humanitarian issue. And the reason they mention this is because there was fear and panic on the part of physicians who now were really being told opioids have no role or very limited role in chronic non-cancer pain. And instead of being able to actually help figure out, well, what do you do when you have patients who were kind of caught in this opioid prescribing debate, that there were doctors who were saying, you know what, I don't want to do this anymore. I can't do this anymore, and kind of abruptly cutting back on pain medication. And sometimes leaving patients to suffer, as Maya Slavitz had said in this New York Times article. So that was something that over 100 scientists, physicians, pharmacists, pain experts, nurses, it led them to really sign this letter calling for a more humane, patient-centered, and thoughtful policy on opioid tapering. We even here in Maryland had heard of reports of patients who were cut off from controlled medications without warning. I, for example, had a patient who called and said that their surgeon abruptly, when they found out that they had been getting, taking more than prescribed, all of a sudden just cut him off and wouldn't even see him anymore, talk to him. And we have seen that there have been assumptions and judgments that have been made about patients based on stigma of addiction, stigma of chronic pain. And unfortunately, that stigma has really caused patients some significant issues. The problem is that we don't have a lot of empiric evidence on opioid tapering. So there has been little guidance um, in the literature on how do we effectively address patients on these chronic opioids, and how do we then taper them off. Most of the recommendations until recently have come from opioid withdrawal management protocols that have been used for opiate use disorder in residential medically monitored settings. And those have often employed a 10% reduction in opioid doses every week. And when you look at actually the outcomes for what happens with those patients after they have completed their opiate withdrawal management protocol, that there are significantly elevated rates of relapse, sometimes up to 80 to 90% for the opiate use disorder with this type of intervention. So there has been alternative recommendations that come from the methadone experience for the treatment of opioid use disorder, where dose reductions are small and separated by very long intervals that sometimes take months or years to taper somebody off of the methadone. That has also has some pros and cons to it, but maybe another kind of base of some evidence that we can kind of look to. So as a result of all of the concern of the unintended consequences from this tightening that happened around 2016 to all the way up through 2017, we have had other efforts to try and right that pendulum that really came to fruition last year. So last year, there were three key elements that came out in the literature to help really try and provide some better guidance for physicians and patients on what to do with these kind of the patient population that has been stuck in the middle. So the first is that there was a clarification of the 2016 opioid prescribing guideline published in the New England Journal of Medicine by the authors of the 2016 guideline. There was also an editorial that highlighted conversations with patients about opioid tapering, really emphasizing that it's the voluntary nature and patient buy-in that is so critical, and that forced tapers really may lead to unintended negative consequences and adverse consequences for patients. The third was that the FDA actually came out with a drug safety announcement around this topic. So the New England Journal of Medicine, as I mentioned, really speaks to that unfortunately there were some policies and practices that may have been derived, sometimes with very noble intent, but that were derived from the guideline that have in fact actually been inconsistent with and sometimes have gone beyond its recommendations. That really thinking carefully. So Debbie Dow from the CDC went on as the other co-author of the editorial in the Annals to say that clinicians have a responsibility to carefully manage opioid therapy and not abandon patients in chronic pain, and that obtaining patient buy-in before tapering is a critical and actually not an insurmountable task, and that there are tools available that we're going to talk about that really help us do that. And then finally, the FDA safety announcement, as I mentioned, where the FDA identifies harm reported from sudden discontinuation of opioid pain medicines and requires label changes, in fact, to guide prescribers on gradual, individualized tapering. So we now really have an environment, not only kind of an evidence. We have some data that we can kind of use, not a whole lot, but we are gaining experience as well with how to manage patients and really think about kind of the who, what, when, and how, and why to taper opioids, um, and an understanding from the regulatory bodies at the CDC and the FDA that we really need to do this kind of perhaps in a gradual, individualized way. Even in Maryland, where in the Maryland PDMP, the Prescription Drug Monitoring Program, we now have an alert center, and a note that while there is great data that we can get in terms of patients who may have experienced overdoses, that there is a cautionary note here that abrupt discontinuation of a prescribed medication has inherent risks. And the notification of the potential overdose event is really meant to aid in clinical decision making. That it might include assessing the need for referral to treatment or coordinating with other providers. And that it is clinical judgment in providing appropriate treatment that really is necessary. Um, and Maryland MACS, or Maryland Addiction Consultation Service, is there to help assist as well. So since the beginning of last year, in partnership between the CDC and SAMHSA, HHS has come out with some federal guidance and a number of different tools to really help providers now take on this complex yet not insurmountable task of really thinking about opioid tapering. In a nutshell, the guidance focuses on individualized care. Really, there are no standard protocols that are going to be able to effectively help manage this issue. That it also really is going to take a team. And the guidance emphasizes team-based care and care coordination. Whether it's a team that is put together inside a practice, or whether you actually even have to go outside the practice to get all the team members and the expertise that may be needed. And the guidance presents situations in which tapering could be considered, but there really importantly are no absolutes, just as there are no absolutes in many, many areas of medicine. And this box here just talks a little bit about why the guidance really emphasizes these 3 points, because the risks of a rapid opioid taper can be pretty significant. It can lead to acute withdrawal symptoms, exacerbation of pain, serious psychological distress, and thoughts of suicide. There have been cases reported in the literature of individuals who have committed suicide in situations in which they have been abruptly or drastically taken off of their opioids. And from an addiction medicine perspective, it can be there can be harm from this, particularly when people turn to illicit opioids, especially now with fentanyl and illicitly manufactured fentanyl as the opioid that has predominantly been available on the street. So unless there are indications of a life-threatening issue, HHS does not recommend abrupt opioid dose reduction or discontinuation. So we talked a little bit about when to consider the taper, as noted in that box. Imminent risk of significant harm because of the opioids. And really, what the guidance now discusses is that doing a risk benefit assessment and doing that on a regular basis in somebody who is being prescribed chronic opioids or persistent opioids for longer than 3 months continuously, and really weighing the risks against the benefits. And when When the risks seem to outweigh the benefits, that may be a time to really consider a taper. Um, what are some of those situations? Well, there may be situations in which intolerable side effects develop, such as severe constipation, small bowel obstruction, um, significant horrible nausea that really can't be controlled. If somebody actually has an opioid related overdose, that certainly is a clinical situation in which you would want to really talk to the patient about that the risks may be outweighing the benefits at that point. If there's worsening of other conditions, so for example, if the patient is experiencing falls or worsening of obstructive sleep apnea, having confusion, um, those are signs that perhaps the adverse side effects of the opioids may be outweighing any potential benefits. If there has been minimal benefit in pain improvement or no improvement in functionality, sometimes that becomes a little harder to really tease out. Um, but if the patient really is not benefiting much and minimal benefit in pain improvement and no improvement in functionality has really been identified as less than 30% benefit and beneficial change on a pain scale such as the PEG, which is um, a 3-item, very brief, very easy to perform in the office tool that can assess how somebody's pain and functionality is improving in response to opioids. PEG being standing for pain and pain improvement. How much has your pain improved over the past week? Or what has your average pain level been over the past week? Um, E being how much has your pain interfered with your enjoyment in daily activities over the past week? And then thirdly, the G, how much has the pain interfered with your general activity over the past week as well? Um, and because the risks of opioid overdose increase with higher opioid doses, particularly 90 milligrams or morphine milligram equivalents or higher, if there are higher opioid doses without any evidence of benefit, that may be an indication to just at least try and reduce the dose. And surprisingly, when patients actually request to lower the dose, in many instances, that may not be, we would like to think that it actually should be listened to, but surveys have identified that anywhere between 50 and 80% of patients who are prescribed long-term opioids would like to actually try and taper, either reduce their dose or taper completely off. So this is something that we should be asking patients about. How do you feel about coming down or coming off? Clearly, when the pain improves, that may be a time to consider trying a lower dose. And then, especially when there's concern for opiate use disorder or addiction. And we'll talk a little bit more about that. I think the key point here is that opioid use disorder and addiction is a specific diagnosis that happens in individuals who take an opioid. However, anyone who takes an opioid in a sufficient dose and duration for any reason will develop what's called physical dependence. And that is not the same as addiction. We now know that addiction is really it's a chronic brain disease that happens in a subset of individuals who get exposed to opioids, whether by prescription or not, and that while there is an overlap, and that for opioids in particular, people who have an opioid addiction will also often have physical dependence, that people who develop physical dependence because they are taking their opioids every day, 60 milligram morphine equivalents or higher for at least a week, that they will develop physical dependence as manifested by tolerance and withdrawal. but they may not actually have that addiction, that compulsive, uncontrolled use and continued use despite harmful consequences. So physical dependence in and of itself is not an indication for tapering opioids. So a little bit more taper context. I think one of the things that also to think about is we know the prescription opioid death rates have declined, but they're still very high, as we've mentioned. And these are um, risks, these are statistics that we can share with patients to help them understand why we may be thinking that the risks are outweighing the benefits. We know from CDC data that as of the first months of 2018, 17% of all opioid related deaths only involve prescription opioids. So it still is something that we want to make sure patients understand. We can also talk to patients about the fact that opioid induced hyperalgesia, or that pain that actually is worsened with opioids, that pain may improve when we reduce their opioid doses. That sometimes is hard for patients to believe, but it is part of the education and part of helping to obtain that buy-in that is so important. And understanding and telling patients that, people can have pain and opiate use disorder at the same time. And when and if that happens, there are effective alternative options that exist. And that just because somebody develops an opiate use disorder or has an opiate use disorder does not mean that we want to ignore their pain. We want to really be able to treat that pain as well. It may not involve the opioids that they have actually been prescribed. It may involve other interventions as well. So those are all good things to think about when talking to patients about um, those risks outweighing the benefits and making that individualized assessment for each patient as to where they are with respect to that risk benefit analysis. And doing that frequently, perhaps even as frequently as quarterly, to really ensure that patients are either continuing to benefit from those opioids or maybe at a position where perhaps we could consider a taper. So how to then think about tapering those opioids? Well, there's some guiding principles that have come out not only from the experience the prescribers have had and pain management specialists have had, but also then from the HHS and other guidance. So as we've talked about already, patient-provider communication is key. And I think one thing that sometimes patients forget, and we forget, is that when they hear the words taper, they think automatically, oh, you're going to cut me off, you're going to take me off. I'm not going to, or the next day or next week, I won't have any medication. And that contributes to a tremendous amount of patient anxiety and fear and panic and resistance. So really differentiating between what may be dose reduction, let's try a small reduction in your dose, and maybe even not talk about kind of full taper to off. Maybe we start with just seeing how you tolerate a small reduction in your dose and making sure that we have while we're doing that, we're not worsening your pain or your function. And making that shared decision with the patient, providing the education, and leading patients actually to a place where they really voluntarily want to try this. As I mentioned, surveys really suggest that large percentages of our patient population who are taking long-term opioids really would like to actually try coming down, if not fully coming off. Thirdly, using a biopsychosocial model of chronic pain. So we now know that chronic pain involves biological components, psychological components, and social components. And if you are familiar with addiction medicine, you will know that those are the same components that are really involved in addiction. Not that chronic pain and addiction are the same thing, but when we're thinking about these complex multifactorial um, conditions where the central nervous system essentially has really been kind of taken over by something that is not productive, and not a productive kind of way of responding to external stimuli, internal stimuli, reward, pleasure, displeasure. Um, it's really worth thinking about kind of what then are effective interventional components for such a complex condition. And so thinking about really making sure that we can address all the biology, the psychology, and the social isolation that happens in patients who often have chronic pain. Avoiding re-traumatizing patients. So this is a big one because similar to patients who have substance use disorders, that patients who have chronic pain have often experienced significant amounts of childhood trauma that actually may be predisposing them to developing chronic pain, um, and trauma throughout their healthcare experience, with having people and healthcare providers treat them kind of with the stigma that sometimes goes along with chronic pain. Team-based approaches, as we've talked about, and identifying and treating depression. So again, really using that biopsychosocial model and understanding that depression is extremely prevalent in patients with chronic pain. And if that is left unrecognized and untreated, can make opioid tapering significantly more difficult. Maximizing non-opioid pain management therapies. This is really important because it's not enough to just take away the opioids. The pain is still going to be there, however that is experienced by the patient. And so understanding kind of what are the components of the pain, what types of pain are involved. Is it nociceptic pain primarily or neuropathic pain? Is it depression and the pain of depression? And really maximizing all those non-opioid pain management therapies even before we start the opioid taper, or and um, naturally as the taper may begin. And frequent follow-up. Some of the two studies that really have been done in the last 2 years around opioid tapering um, have found that the frequent follow-up is what has um, led to the most effective outcomes. And that may be weekly. It may be a weekly phone call. It may be having patients check in with peers, um, or community health workers. So really kind of using that team-based approach to make sure that the patient is connected. So then we get to the mechanics. So how do you do this? So the big goal, the primary goal, is to minimize opioid withdrawal, because opioid withdrawal is associated with increased levels of pain. And when that happens, the patient may be very reluctant to continue the taper. Using an individualized taper plan can help with minimizing opioid withdrawal, and going slower is better. The slower you go, the less opioid withdrawal someone will have. To really come up with an individualized taper plan, it's important to consider the half-life of the opioid that is being tapered and what the starting dose is. So the recommendations now really are that um, go no more than 5 to 10% of the dose every 4 weeks. It might be that you start with 5% for the first week, for the first 4 weeks, and then perhaps actually talk with the patient about maybe they would like to try and go up to 10%. That was the strategy used in a small study done a couple of years ago in San Francisco at Stanford, and seemed to have pretty good engagement value. Resetting the absolute dose reduction as the taper proceeds. So really looking at how is the patient responding to past dose reductions, and resetting those percentages as things move along and as patients can tolerate. And not worrying that tapers can take months to years, and that is okay, as long as there is no imminent risk of harm from the opioid itself. and even considering taper pauses if patients are struggling. Again, there is no necessarily significant urgency to this unless there is imminent risk from the opioid. And that once a patient is taking an opioid less than once a day, you can actually then completely discontinue the opioid itself. And consider buprenorphine. So I'm going to share a story with you of a patient of mine, Miss DC, who is a 39-year-old woman. She's a veteran. She came to me with chronic low back and left leg pain from sciatica and PTSD. And she came because she'd been prescribed high dose opioids for years after failed back surgery. She had actually parachuted out of an airplane while in the service, and the parachute had not opened on time, and she ended up with significant fractures in her back and her legs and her shoulders. And she had been prescribed oxycodone, uh, OxyContin, 40 milligrams twice a day, short-acting oxycodone, 30 milligrams Q4 hours. So a total oxycodone dose of about 260 milligrams a day, which is equivalent to, it's an MME of almost 400. So she was at extremely high risk for many of the adverse consequences of opioids. And in fact, she had herself recognized that she was starting to develop an opiate use disorder. She had almost, she had lost her job. Her husband had come home and found her just lying around on the couch and threatened divorce. They had to move into her husband, her in-laws' basement, and she was just sitting around on the couch all day, smoking hookah and taking pills. Not, I think, not hard to see how she would meet the diagnostic criteria for an opiate use disorder. And she had actually begged her pain management specialist to taper the opioids and prescribe buprenorphine, but had been told that that was unavailable. So she came to me really looking for an alternative. And the alternative that we went to was buprenorphine. And the way we did that was that she took her last dose of oxycodone or OxyContin, the sustained release, on the morning before starting the buprenorphine, and her last short-acting oxycodone at 9 p.m. the night before. We did a COWS when she came in. It was 12. And so we started a small dose of buprenorphine at 4 milligrams and titrated it up to 4 milligrams 3 times a day. And eventually she ended up on 8 milligrams in the morning, and then 4 milligrams at noon, and then 4 milligrams at bedtime. She also received other adjunctive meds, so topiramate, baclofen, and venlafaxine. That was eventually tapered off because she didn't like the side effects. And she came for weekly individual counseling sessions and eventually went back to work. Her pain got much better. She moved out, got a divorce from her husband, moved out, has her own place, and has been stable now with improved pain and functioning for almost 4 years. And has been using the buprenorphine to actually treat any residual pain that she's had. But getting to a point where she only really needed buprenorphine twice a day and using it now more to treat her opiate use disorder rather than just the pain. So buprenorphine has really kind of taken on a potentially more central role in not only an opiate use disorder where it's become standard of care, but also now when we're thinking about how do we help patients who are really struggling with their taper. This is a clinical pathway that comes from a paper that Robert Chu and Jane Ballantyne co-authored that came out in Annals of Internal Medicine last year. And essentially, it is a proposed clinical pathway that really looks at how do you think about kind of opioid tapering in people who are taking opioids long-term for chronic pain. And starting with that systematic assessment of risk and benefits that we've talked about, And in places where the benefits outweigh the risks, really making sure to document that and then continuing to assess it. But these may be individuals who may actually benefit from their chronic opioid use. And on the left side here, if there is a situation where the risks outweigh the benefits, to again kind of talk about, suggest, explain, really work with the patient so that they are at a point when they voluntarily would like to reduce that dose. And when that starts to happen, then often we find that there are people who are able to taper the dose and really may get down to a dose that has much less risk, so less than 50 mmes a day, less than 90 mmes a day, and continuing to reassess and really see kind of where does that patient actually then um, hit that point where perhaps they actually have benefits that outweigh the risks. But then there is a subset of patients that are going to struggle. They have a very difficult time tapering that dose. And Chu and Valentine suggests that it might be that in that population, some percentage may meet the diagnostic criteria for an opiate use disorder, in which place, like Ms. DC, maybe transition to buprenorphine or some other treatment. You may be able to actually use the buprenorphine off label for their pain and on label to treat their opiate use disorder. Now, Chu and Valentine also describe that there may be this diagnosis of prescription opioid dependence that has not, there's no ICD-10 code for this, no ICD-11 code for this. It is not found in the DSM-5, but that it may be people who don't necessarily meet the diagnosis of an opiate use disorder and the diagnostic criteria, but just have a very difficult time getting off or reducing their prescription opioids. And the recommendation from Chu and Valentine here is to also really consider buprenorphine or slow down the taper and see if that makes a difference. But regardless, I think even to me, whether the patient has a diagnosis of an opiate use disorder or a prescription opioid dependence, the role that buprenorphine can play in helping patients who have difficulty with this taper and still have pain, buprenorphine is really something to consider in that patient population. Just another quick note to say that buprenorphine also, there are formulations that are specifically indicated for the treatment of pain, but not the treatment of an opiate use disorder. And so just recognizing that in order to prescribe buprenorphine for an opiate use disorder, that requires a special waiver from the DEA. That is not the same if you are prescribing the other formulations for the treatment of pain. That then does not need an X waiver. But in this situation, to be on the safe side, it is possible to also use your X waiver, particularly if the diagnosis is an opiate use disorder. So just some few other last thoughts about how to kind of manage then this opioid withdrawal and minimize it. The best treatment, as we've talked about, is avoiding withdrawal altogether. But if it develops, there are symptomatic medications that can be used to help with some of the most troublesome symptoms that patients may complain about. So NSAIDs, acetaminophen for those myalgias, ondansetron for nausea. I would avoid promethazine or Phenergan, just given that it has more side effects than ondansetron, and particularly in a place like Baltimore, there is also some street value. And so even if the patient themselves doesn't have, is not at risk for diversion, there may be family members or friends or others in the household that may be. So trying to avoid that. Trazodone for sleep, avoiding benzos or the Z drugs, particularly because the combination of opioids and benzos is associated with a higher risk of overdose. dicyclomine for abdominal cramping, if that is needed. And then many symptomatic treatments and treatment regimens for opiate withdrawal have included clonidine in the past. Clonidine can certainly be used to reduce some of the anxiety and agitation that very often is extremely distressing to patients who are experiencing opiate withdrawal. And now there is the FDA approved lofexidine a couple years ago for the treatment specifically of opioid withdrawal management. It does not, there is no specific indication for whether that opioid withdrawal management is from opioids in someone with an opiate use disorder or opioids from pain um, or opioids that are being used for pain. And so that may be another consideration. And then the federal guidance really wanted to specifically highlight a few things of what not to do, because these are the practices that sometimes then get patients and prescribers into trouble. Avoid misinterpreting cautionary dosage thresholds as mandates for dose reduction, really thinking that about this as a risk-benefit assessment and a voluntary patient-centered tapering effort. Avoid insisting on opioid tapering or discontinuation when opioid use may be warranted. Avoid dismissing patients from care, not abandoning patients, and ensure that patients continue to receive coordinated care. Avoid abrupt tapering or sudden discontinuation of opioids. So really using that team-based approach, using your colleagues in addiction medicine and pain management, um, and making sure that we don't forget patient and family identified supports, um, and listing them in this, especially in opioid overdose prevention education, and making sure that people are leaving offices either with a prescription or an naloxone 4 or an naloxone kit. So people may, say, prescribers, other healthcare professionals may say, well, Dr. Olsen, this is all great and well, but we can't get coverage for all effective therapies for chronic pain. And it is absolutely true that there's some system level needs that we need to pay attention to make opioid tapering as successful as possible for patients. And that includes that adequate coverage. A note just that the Medical Society of Maryland, MedChi, has been working with Care First to make sure that there is adequate coverage of all effective therapies for chronic pain. Having coordination between prescribers of opioids and addiction medicine colleagues, as I mentioned. There are organizations in Maryland, including the Maryland DC Society of Addiction Medicine, that are really interested in becoming more involved as an organization with prescribers of opioids. And really looking at how do we do shared learning on effective models of care, patient communication strategies, and accessing community resources. And that's where the Maryland Addiction Consultation Service can be extremely helpful. So the take-home points I just wanted to leave you all with is that communicate, communicate, communicate. Communicate with your patients, communicate with your colleagues, communicate with your specialists, specialist consultants, communicate with family members, and communicate with your team members, because it really does take a team to help and assist patients manage this this sometimes really kind of anxiety-provoking topic of opioid tapering. Discuss and reevaluate end goals with patients and care team. Maybe not even focusing so much on that it's we want to take you off this medication, but really how are we going to better help you gain function and not lose the pain improvement that you may have had to the extent that you did with the opioids. So focusing more on improving life and quality of life as opposed to just kind of the opioid tapering. And having patience of the CE kind. This may take time, and that's okay. It is chronic. Pain is chronic because it lasts a long time, and it may take them a long time to really get people to the point where we all want. Because ultimately, people really need to see that you care before they care what you think. That's certainly something that we have learned in our clinic and my clinic experience, and that when people really understand that you care about them, they often will go along with you, and because they trust that you're going to be there with them. So here are some of the resources from not only the HHS, as I mentioned, but the CDC has a wealth of resources around opioid tapering. The Stanford Center for Continuing Medical Education has a whole uh, website dedicated really to how to taper patients off of chronic opioid therapy, and some great CME curriculum and courses on how to do that. So at this point, we are going to take any questions. And if after this webinar you continue to have questions or have other questions that you felt weren't answered, please feel free to contact Tracy Summer at the website listed here, tsummer@som.umaryland.edu, or always, as always, on the Max line, 1-855-337-MACS 6227. Thanks so much. And now questions. Let's see, do we have any questions? Okay. Does anyone have any questions? So I don't see any questions. Okay. So if anybody has any questions and wants to be unmuted, if you type in the chat box, just type in the questions, I'm being told. Okay. All right. Well, if there are no questions, thank you so much all for joining us today and this afternoon. Just a reminder that, again, you can always reach us at 1-855-337-6227. That is the Max line. Or on the there are resources on the website, www.marylandmacs.org. And have a great afternoon.